Hi, this is class song. We're group 7 and we're here to present the presentation of the latest trends in electronic health record in different countries. In this presentation, we're going to be presenting from the background of 4 different case studies from Hong Kong, Singapore to Canada and Australia. We're going to be comparing those case studies and then make a conclusion. What is EHR and who are using them? EHR stands for the Electronic Health Record, which is an individual multiple physician-generated electronic medical record and the patient-generated personal health record. It is intended to be comprehensive, and it should facilitate optimal management of the health of an individual or when used in the aggregate of a populations. EHR should allow sharing of information about patients between any authorized provider. A patient should be able to enter any healthcare setting, providing authorizations, and then consult with the provider who has ready access to their complete health record. And how EHR will impact our life? There are some applications of EHR can be applied for. It can firstly be applied to the primary care setting, which is usually the family caregiver, the family physicians, and all the other primary care. And it can also be applied in ambulatory care, which is usually the clinic that you go to. It can be applied to the academia research, the clinical research, and the medicine trial, etc. It can also be used to support the population health, as well as the public health surveillance, which can be used kind of widely during the COVID circumstance. There are some benefits that EHR should be adopted. The overriding reason for us to use this technology is to have all the information that we needed to patient care, for education and for practice management readily accessible as a point of care. It should not matter whenever and whether the computer terminal is in our office or at clinic, or like the workstation or at home, examination room, or any place that it can be. The EHR itself can enhance the tracking and monitoring of the quality of our care activities. On the other side, EHRs include reductions of medical errors, reduction of loss of redundant paperwork, and support for the work. It is also a very useful tool to link patients, practice, clinic, imaging centers, hospitals, health plans, and all the other medical systems together, and to ensure all of which are in a confidential, secure, and standardized format. And at very last, computers today are inexpensive and very easy to get access of. The transition to electrical formats is almost inevitable for today. Accordingly, there are some histories of the health records can be provided. Translations of ancient Egyptian hieroglyphic inscriptions in papyric from 1600 and 3000 BC indicating the use of medical records, but paper medical records were not steadily used until 1900 and 1920. Traditionally, health record was written on paper, maintained in a folder divided to 2 sections based on typo notes, and only 1 copy was available. New computer technology developed in the 1960s and 1970s laid the foundation of the developments of the electrical health record. The use of EHR was not only used patients' medical information easier to read and available from almost any location in the world, but also changed the format of the health record and thus changed healthcare. Some EHRs developed between 1971 and 1992 were developed with hierarchical or relational database. Around were added on hospital buildings and schedule systems, while others were developed as clinical systems to help improve medical care and for use in medical research. As inadequacies of paper records become increasingly more apparent in 1992, the Institutes of Medicines advocated a shift from a paper-based to electrical medical record. In the late 1980s and the early 1990s, hardware became more affordable, powerful, and compact, and the use of personal computer, local area network, and the internet provided faster and easier access to medical information, and initiated the use of white-based EHRs. By 2025, EHR records are now being created, used, edited, and viewed by multiple independent entities, including primary use physicians, hospitals, insurance companies, and patients. EHRs are increasingly being used in primary care exam room to document and assess patients' records along with online medical information. Whereas the world as a whole is still far from seeing the end to paper record, there has been a very rapid expansion in the last 5 to 10 years, to the point where now, in some countries, nearly 90% of all healthcare records are digital. However, it might vary from country to country. Which brings to the question, why is comparing EHR in different countries so important? The reason why we think it is so important is to compare EHR in different countries is that EHR has been very important to healthcare workers for over a decade. It is constantly evolving. It will be interesting to see what other EHR be like. We're interested in know how their development in terms of pace and difficulties and implementations is. Our end goal is to learn from other mistakes and try to improve our own. Therefore, it is also important for us to find some of the common things we experience while EHR is being implemented and try to prepare ourselves for the future.
So I'm going to talk about the case in Hong Kong. Before I go into EHR in Hong Kong, I need to give you the background first. So the healthcare in Hong Kong is supported by the public and private sectors. The Hospital Authority is the statutory body that manages all government hospitals and clinics. The Department of Health and other public healthcare providers are more of a supporting role in Hong Kong healthcare. So there has been a gap between the public and private sectors because they do not have a common database before. So it caused a huge service gap between them, and they're unable to fully support each other. Clinical management system is the foundation of the current EHRSS, which is the Electronic Health Record Sharing System. It is developed by the HAs in 1992. It can only be accessed by the hospital authority hospital networks. The purpose of it is to support clinical work, to help record patients' data, history, their documents, to provide decision support systems, and an order system for clinicians to order drugs or treatments. Over the years, more features were added, like the web-based client, seamless features, integrations with other phone apps, and the Wi-Fi capabilities. The Electronic Health Record Sharing System (EHRSS) was launched in 2016 with an emphasis on patients' privacy and data security. The patient's EHR was shared in a need-to-know basis by the patient's authorizations. It was shared with the hospital authority, Department of Health, and other individual private hospital or other healthcare providers. It was completely voluntary, free of charge, and the patients can withdraw anytime they want. It allows patients to choose their own service, so there's no more service gap between the private and public sectors. Here's the roadmap to Hong Kong eHealth. So the development of the clinical management system, which is the foundation of Hong Kong eHealth, started in 1992. In the first 10 to 12 years, it focused mainly on the infrastructures and the service expansion. In the past 10 years, major projects such as the Feminist Project, IPMOE, and HAGO had greatly enhanced the capabilities of CMS and the Hong Kong overall eHealth system. The surface coverage of the electronic health record improves over the years. It started in a few hospitals in 1992, and the surface expansion started in 2014, where more services are added. The coverage improves to cover other private sectors in 2016 after the launch of EHRSS. The expenditure of EHRSS is estimated in a total of 1.1 billion. To give you a context, HAIT investments from 1991 to 2016 is 2.4 billion. Legislature and the related assessments were kick-started since the development of EHRSS. Legal, privacy, and security frameworks were formulated in 2012, and the EHR bill was drafted in 2013. The complete legislation process was finished in 2015, before the launch of EHRSS. Most users are happy with the systems. On the Apple App Store, it got a 4.3 ratings and 5 stars in Google Play. Clinical users are also happy with the systems. It improved the efficiency by lowering wait time and improved patient safety by minimizing errors. The system's also able to adapt to crises like the SARS, flu, and COVID-19. It improved the management effectiveness with the clinical data analysis and reporting system. It is the single most used tool by clinical operators.
Now we will look at Singapore as an example. The National Electronic Health Record is the electronic health record system. Singapore's government created a 10-year master plan, Intelligent 2015, with the goal of transforming the country into an intelligent nation and global city powered by information technology. For the health sector, the project aims to accelerate its transformation by implementing an information technology-enabled personalized healthcare delivery system that enables high-quality clinical care, survey excellence, cost effectiveness, and strong clinical research. This purpose is being served by the development of the National Electronic Health Record. By providing authorized doctor and healthcare provider with secure real-time access to patient health records, the NHR serves as a platform for the exchange of health information across the healthcare continuum. The project's goal is to provide each patient with a personalized health record. One patient, one health record has the vision of creating the unified health record for each patient, thereby improving the quality of care for all patients by increasing patient safety, lowering healthcare costs, and developing more effective health policy. The NHR program was established in 2009. The first phase of the program was launched in 2011 with 15 care organizations participating. It began its long nationwide rollout in 2012 and long health hub and online portal in 2016. In 2020, the update was made to make the requirement of COVID-19 outbreak. The NHR has gradually been implemented in Singapore public and private healthcare facilities. Since 2011, a total of 1,728 organizations have participated in the NHR, and around 500 patients have opted out the NHR program. 40 of them have opted in after being consultation. An individual HR is referred to as a summary card record in Singapore. It is a copy of vital information from a patient medical record. It gives authorized healthcare professional a complete picture of your medical history. The information includes admission and risk history, hospital inpatient discharge summary, laboratory result, radiologic result, medication history, history of previous operation, allergies and adverse drug reaction, and vaccination. The Health Hub app was created to give Singaporeans a single point of access to their personal medical record, linked to healthcare services and institutions, and related information and tools. In comparison to public healthcare providers, private healthcare providers are least interested in contributing information to the NHR. By 2012, the system adoption rate in the private sector have increased slowly, with only 27% of doctors with private license using it. To encourage greater adoption, particularly in terms of data contribution to the NHR, the Singapore government developed the Early Contribution Incentive to assist the license. ECI is a one-time financial assistance program designed to help organizations offset the cost of system upgrades or increase the subscription costs associated with data contribution to the NHR. In terms of legislation or policy, the Personal Data Protection Commission was formed in 2013, and the Personal Data Protection Act, which established a minimum standard of data protection in Singapore, went into effect in 2014. In terms of user certification, the majority of doctors support NHR. They claim that by allowing doctors to view the result of recent investigation, the system improves the quality of care provided, increased patient safety, and lower client costs. Then we move on to the case study of other countries.
In the following, we will talk about the Electronic Health Record in Canada. Health Interway is a non-for-profit organization established in 2001, which aims to establish a digital record that will be accessible to every patient in the country. Its establishment is supported by the federal government. They may focus investments for up to 75% to foster EHR development across the country by setting up national direction and national infrastructure, enabling greater interoperability within and across jurisdictions. A shared approach also guarantees that movement of knowledge and people across jurisdictions is simple. that platform quality nationwide is equal, and that cooperation between different parts of the system is possible in terms of the system design and vendor negotiations. They developed and released EHR Solution Blueprint in 2003 and launched SS 2022 in 2018. So what is EHR Solution Blueprint? It's a technology framework for sharing health information securely and appropriately across Canada published by Health Information, which was starting point for a nationwide infrastructure with a shared foundation of hardware, software, and communication technologies associating architectures and working principles that enable an uninterrupted flow of information. The blueprint created a common vision and important definitions for the main solution components, allowing jurisdictions and info to work together to align EHR initiatives with a pan-Canadian architecture as well as the common standards for semantic interoperability. It is released in 2006 and includes more details on how standards support the sharing of health information and how they comply with federal, provincial, and territorial requirements as well as the privacy and security requirements across jurisdictions. The first version of the blueprint came out in 2009. This included privacy, security, architecture, and clinical terminology integration projects. The challenge was how to integrate the 40,000 existing health information systems in use across the country, while at the same time providing the opportunity for incorporating new and enhanced information systems and capabilities in support of the provision of care. The following graph is the Canadian interoperable EHR architecture. In the architecture, a jurisdiction's point-of-care operational information systems manage and store patients' clinical information. A central EHR repository and domain-specified repositories combine their information at the jurisdictional level to provide full clinical patient information to any point of care. The Health Information Data Warehouse provides patients longitudinal record services, including an ability to extract, transform, and load EHR information into the warehouse. The registry service support the accurate and unambiguous identification of patients, providers, and the location of service delivery. And EHR viewer facilitates the ability for health providers to access shared EHR information for those who do not have an EHR-enabled application at the point of service. Public health surveillance can also use the infrastructure to provide service system responses. EHRs are tied together by the Health Information Access Layer, a set of info-mandated specifications for integration, interoperability, privacy, security, and other services. In general, each jurisdiction will have its own HIAL. HIAL will follow a similar design and architecture will use the same standards, although the vendors may be different. Therefore, patient health information is made available across different locations and jurisdictions by way of interconnecting the EHR infrastructure via the HIAL. In Canada, there are two levels of privacy legislation, both at the federal level and provincial level. At the federal level, laws relating to privacy rights include the Privacy Act, which governs the way federal government institutions handle personal information, and the Personal Information Protection and Electronic Documents Act, which governs how private sector organizations use personal information. Generally, however, publicly funded hospitals are not regarded as commercial bodies, and their use of personal information is regulated by the provinces and territories. On the other hand, the Office of Privacy Commissioner of Canada's website explains that private health practitioners and privately funded long-term care facilities, nursing homes, retirement residences, and home care services are generally considered to be conducting commercial activities. PFEDA will likely apply to their personal information practices unless substantially similar legislation exists within the province or territory. The Pan-Canadian Health Information Privacy and Confidentiality Framework is a guide to assist organizations that handle personal health information in putting in place some privacy practices. It will also serve as a reference point for broader policy initiatives, such as updating legislation. Institutions must develop and maintain privacy impact assessment to evaluate whether program and service delivery initiatives involving personal information comply with privacy requirements and to resolve privacy issues that may be of potential concern. Under Treasury Board Secretary policy, or departments and agencies must conduct PIAs for proposals of all new programs and services that raise privacy issues. The PIA goes through an internal approval process before being signed off by the Deputy Minister and sent to the Office of the Privacy Commissioner for review. For the expenses, start from 2001 to 2017, The federal government has provided totally $2.45 billion to support health information on the EHR developments, including the following projects: a pan-Canadian health surveillance system, national EHR implementations, digital health activities in e-prescribing and tele-home care, virtual care visit, and helping patients to access their own health records electronically. For the adoption rate, it shows the changes between 2016 and 2021, with the estimated 500,000 healthcare professional users. The estimated monthly users gradually increasing, but it is commented as a low increasing rate. Healthcare professionals generally show positive attitudes to service and system quality, accuracy, and availability of information, user satisfaction, workflow integration, and productivity in accessing diagnostic imaging and digital imaging. There are three aspects of barriers found, which include the sociocultural, technological, and policy setting. First of all is sociocultural barrier. Physicians' age, specialty, and comfort level with technology play a role in the EHR implementation. Some physicians are too comfortable with the status quo and simply don't want to change. 42% of family physicians are more likely to use electronic-only systems, compared to only 17% of specialists. Similarly, the younger doctors who are age 35 or younger use fully computerized systems, whereas 36% of doctors age 65 or older are completely paper-based, and only one-third of them plan to adopt EHRs in the next 2 years. Next, for the technological barrier, EHRs face several technical problems such as inadequate infrastructure, slow system speeds, unexpected outages, and unreliable rural access to the internet. While some physicians may want to adopt new systems, they may not have the required skills. Also, some medical practices or clinics may have the problem synchronizing the EHR systems with clinicians' workflow. Moreover, access to different EHR vendors in different jurisdictions can also be a problem. The medical practices may lack on-site personnel trained in IT and project management, or due to location, lack external support in these areas. After that is the policy setting barrier. There is a lack of an effective policy setting authority. Canada InfoWay has very little governance and is a funding agency, not a policy setting body. Stronger leadership is needed to align the national e-health policy with the health system's needs. Stakeholders are dissatisfied with the current political support, and they question Canada's InfoWay's ability to meet its target. A national policy setting authority will provide greater transparency and accountability for funding and spending. Independent analysts could assess, track, and monitor e-health developments and provide impartial data to justify government's expenditures. For the future plan, there have the Access 2022 project, which is a movement to promote a future where all Canadians have access to their health information through an availability and use of digital health tools and services. In the 2016 InfoWay survey, Connecting Patients for Better Health, only 22% of Canadians surveyed had access to their health information online, and 73% of those who did not want it. The results of this survey brings the direction of Access 2022 with two strategic initiatives: Access Health and Prescribe IT. InfoWay's Access Health program is focused on providing more Canadians with access to their personal health information and to digitally enable health services anytime, anywhere, and from any device. The Prescribe IT is a national e-prescribing service that enables prescribers to electronically transmit a prescription to a patient's pharmacy of choice, which have the potentially increase the interoperability of health information by getting everyone working from the same system.
Okay, let me introduce the case study of Australia. The healthcare system in Australia is similar to Hong Kong, mixed with private and public healthcare providers, and the patients are moving between two settings regularly. It's operated in no coordination between private and public. In 2010, the Australian government started to develop a e-health system. The government spent over 400 million Australian dollars for development, and the e-health system named Personal Control Electronic Health Records was implemented in 2012. However, PCEHR failed to make a significant outcome because of the lack of participation of the both patient and the healthcare provider. The government spent nearly 500 million Australian dollars to redevelop and relaunch a new e-health system named My Health Record in 2017. PCEHR system aimed to address information fragmentation. The system is a web-based portal that allows patients and healthcare providers to access their health information easily. For the new EHR My Health Records, it's an online system to facilitate both patient and the healthcare provider to trace their information easily. The patient information is stored in a centralized location and can be only accessed by authorized person. PCEHR is an opt-in system for both patient and healthcare provider, which means they have to enroll on the system, and also they are able to withdraw at any time. After they join the system, a 16-digit reference number will be given as the identifier. Then they will easily create a shared health summary which included medical history, medication history, and allergic. Healthcare provider required to upload the record to the system, and the patient could read the information after they upload. And the original data will be still stored in the organization, and the patient cannot be added to the record. However, PCEHR was not being used by healthcare provider. There are only 2% of registered users, and only limited healthcare records has been uploaded to the system. There are 4 points of issue with PCEHR. There is not enough patient register, not enough information in the patient record, poor integrated with healthcare practice, and the system interface was not conducive to the practice co-use. To address the problem, the new EHR My Health Record switching to an opt-out system to create an instant uptake of user. The implementing an opt-out system is dependent on a sufficient amount of patient information being uploaded. And also, is there any clear privacy and security standard? In order to increase the transparency and strengthen e-health governance arrangement consistent, a new entity called ADHD operated in 2016, which is responsible for National Digital Health Service and System, and innovation and clinical quality and safety. And also, to encourage general practice to keep update with the latest development in digital health and adapt new technologies, EPIP program is available to help them to improve the admin procedure and patient care. To make a better digital health platform, interoperability is one of the key issues related to enhance the sharing health information system among healthcare providers. In order to provide the best care and the clinical outcome for the patient, some international standards such as SOA model for EHR framework, HL7 for clinical document, and SOAPMate CT for internal standard clinical terminology has been implemented in the My Health Record for sorting and sharing health information. My Health Record is a link between patient and healthcare provider, just like a hub connecting public and private sector together to perform a single view the information from different systems. The health information can be viewed online from anywhere, anytime, securely. To the latest statistic and insight report from ADHA, we know that how My Health Record is being used by healthcare provider and patient. There are more than 23 million records in My Health Record, and over 90% of pharmacy, GP, and public hospital are registered. And over 5 billion people checking their proof of COVID-19 vaccine, PCR test result, and other key information during outbreak. And there are less than 5,000 people have set up further access control in their My Health Records. We can say that they trust the system security. At the end, it is too early to say that whether My Health Record was a success. A successful e-health system provides opportunity for the software developer and healthcare provider to create a better health service.
Discussion. EHR has become an essential part of the healthcare system in developed countries and cities. It brings great benefits in boosting overall efficiency by reducing manual work and improving patient safety with good features implementation. It also helps research, which is a crucial part in improving medicine and develop future technologies. However, it's not commonly seen in low-income or middle-income countries due to the poor infrastructure and healthcare system in general. However, we noted that there's a rise in demand. Experience sharing from higher income countries will be vital to their development. In the past 10 years, high income countries mostly focus on improving service coverages and geological coverages. We have noticed a common trend here. Services such as X-ray films and lab result access on EHR are only being seen in the past decade, although we had the ability to digitize them years ago. Also, we see smartphone app appear in the past 5 years, but the technology has already existed for more than 10 years. But why? Are we going to see these new technologies like blockchain, 5G, and AI in our future healthcare? You might ask, are these technologies now commonly seen in our healthcare system? Some, but not a lot. Consider how much new technologies has helped improve healthcare. Why are we not seeing new technologies more commonly now? Cost is certainly a concern. New technologies often requires new infrastructure. Building new infrastructure is costly. Making changes on existing infrastructure is even more difficult. Let's say we need to implement a new AI service. We need to add new server. We either use remote server or host local servers. We need to consider hiring professionals to maintain the hardware and software. Also, cost efficiency is a big concern. How much performance boost can it bring to the organization? Is it worth the taxpayers' money? Second, implementing a new tech requires massive workflow changes. Whether it helps improve efficiency is highly dependent on the execution, such as staff training and workflow adaptation. Multiple stakeholders are involved and affected. Third, new technologies takes years to be accepted by the public. In the past, we have the internet and the smartphone. Now we have blockchain and AI. They're still fairly new, and the public lack the knowledge to fully accept them. Fourth, there's a lot of problem with liability and privacy. For example, AI training requires a lot of patient data, and AI assist decision support system leads to liability concern for physicians. The related legislative processes will take immense time and effort. Finally, new tech often lack standard. Developers do not have consensus on how things should be implemented, and everybody plays their own game. To conclude, interoperability is a common issue, but we're very close in completely eliminating it. Different countries have different approach in solving this issue. And in terms of service coverage and features, the EHR we have in Hong Kong is comparable to Singapore's. Some of the new technologies like blockchain and AI are not mature enough for clinical use yet, but we see that automation and Internet of Things is the next big trend and is very likely to happen.